In this short opening keynote, I would like to engage you in my challenge to consider whole system design and its application in next generation healthcare. A grand challenge question here might be, how do we design for a human-centered health system while sustaining our healthcare institutions? I don't have the scope to share a trends analysis, but we'll just ask, are we able to see real signs of next generation healthcare yet? In strategic foresight, the year 2020 was our most promoted year of the future. And when it arrived, did we see its promises? I noticed the COVID pandemic accelerated many once lagging healthcare innovations by its sheer necessity. For example, telehealth was moribund in Ontario before the crisis, and then it became ubiquitous across hospitals and practices within just the first month. Patient portals, email, and text are now used seamlessly. These were all existing previously, yet were slow adoption practices, and they were adopted immediately when necessary. So we might notice that public health and medical services responded to the pandemic largely by increasing and strengthening basic capabilities. Emergency, ICU, care transitions, traditional care clinical services. Yet I've seen few cases of new clinical service design in treatment or vaccine delivery, for example. And coming from Canada, the Australian context is familiar, as our provincial-based systems are funded, organized, perhaps innovated in similar ways. We saw COVID reinforce the demand for centralized healthcare here. 10 years ago, when I was researching my 2013 book, Design for Care, healthcare futurists were adamant that hospitals would be relics by 2025. Over 25% of all hospitals would disappear, they said, due to changing technology and an outdated business model. Did this happen? Well, one of my course teams just finished a systems map, which you see here, taking the form of a game board for social prescribing in Ontario, which is a practice of primary care prescription for better housing or social benefits for health, drawing on community assets for social care. This is a step towards next generation healthcare that might be driven by system level innovation. Perhaps we're starting to see more of this happening. And what else might we see in the horizon? In fact, some of these ideas are in this map. Porter and Lee's value-based care is another system level model with integrated practice units, care service bundling, treated more like subscriptions than insurance. The Obamacare policy models, the Accountable Care Organization, patient-centered medical homes, were designed to facilitate locally led clinical organizations to move toward distributed care. Well, I believe the hospital of the future will be more of a trauma and specialty inpatient center surrounded by community assets for social care and distributed within the community setting. And while I've not yet mentioned systems concepts, these are all systemic issues that I've mentioned to now. In a whole system of healthcare, the public provider and the service regions and programs would define the system boundary, like in this diagram. Here we see nested systems of including regional districts, levels of care, geographic differentiation. Provider networks could all be represented as nested systems within an inclusive healthcare system. There are classical system structures with feedback, technical system integration, high reliability coordination, redundancy and buffers, adaptation to disruption. In high performance systems, such as the hospital, change cannot be too disruptive. Transformation has to be deliberate, coordinated, and slow. So, and as such, we would need, in designing for systems, why aren't we designing for systems level? Well, it is, perhaps we don't have the right models and the practices or haven't integrated it well yet. Let me share a basic systemic design model from my book that helps to frame design across system levels. The 4 domains of design here are areas requiring different design skill and application. All 4 apply in healthcare contexts, but whole system design requires all 4, increasing in complexity from design 1 to design 4, from small team design projects such as websites or patient-centered service and as a service and product design, increasing in complexity up to multi-stakeholder social systems, the organization and whole networks and health systems. So design 1 can be seen as a creative, skill-led traditional design and serves well-defined outcomes. Any designer knows how to do this. 1 or 2 designers working with communication systems, producing websites for a department, for a client. Here we see a series of redesigns of the Journal American College of Cardiology, one of my projects. These recent redesign of the JACC Journals platform is essentially design 1.0 techniques in an organizational and platform setting. So it is more complex than this might look, but the design skills are design 1. Design 2.0 constitutes service and product design for an organization's value offerings to its customers, whether patients or clinicians. In healthcare settings, changing product and service lines can be very complex, and it merges with practice. But the end products can appear simple, such as the redesign of the Canadian hypertension treatment guidelines under the Sea Change program. Shown here is just a simple redesign of the guidelines as presented to practitioners, but also within the Sea Change program, led by a clinical team from Sunnybrook Health Sciences Center, my students have proposed novel service design for approaches for implementing these guidelines to a wide range, so that they can be user-centered and used by a wide range of clinicians and family practitioners. So this model would be intended primarily for family physicians in Canada, as mapped out in the visualization, but it is intensely patient-centered. Let's look at Design 3.0. Consider this a mode of involving organizations and their internal services. These are complex because changing a large going organization effectively is a systems change task involving extensive sense making across all levels of the organization and across roles and disciplines. The map you see here is a business model process of the flourishing business model used in another project with a graduate student to integrate with a Toronto hospital to integrate ambulatory and mental health, looking at the integration of service lines of roles across patient touch points and the business model for this. Now, Design 4.0 would be what then at the whole system or multi-stakeholder level across entire healthcare systems. Here I'd say it depends on your boundary. So the whole system in healthcare is typically treated as the policy and payer provider. That is the Ministry of Health, the whole healthcare system. Here in this synthesis map show the Canadian cancer system this is represented and produced within a major CIHR, Canadian Institute of Health Research study known as CAN Impact. And this shows patient flows across all levels of care in a pan-Canadian view of the cancer system with a focus on reintegrating primary care into the cancer system. And this is within the boundary of the cancer system, but also within Canada. It's a whole system view. And Design 4.0 is almost entirely the design for sense making across multiple stakeholders. So this includes the communities of patients and clinicians and researchers, in this case, the CAN Impact research, but also across the whole system. And if you take that into account, it would be you, the audience, are the designers at this level. You hold the ideation, you are in charge of the decisions, the planning, and the consulting designers, like myself, are merely facilitators. Good facilitators, I might add, but we do not tell you what to make. We do not design the system. We are facilitators of these engagements. And so from my own review, the HEAL labs, the Bridge Labs projects, it seems that we are working in similar territory. OCAD University's Health Design Lab draws on our Master Design for Health program for a wide range of projects and graduate students and professors involved in these projects, very similar to the Queensland portfolio. So for Design 3 and 4, we train our Design for Health graduate students to use methods in the Systemic Design Toolkit, which I'd encourage you to look up from the URL here. There are over 30 tools across 7 stages of design engagement, from framing systems to value creation to implementation, tools for mapping stakeholders and processes, systems mapping, visioning, formal system modeling. The toolkit provides canvases that enable facilitators like myself to work with stakeholders of any kind with no system thinking training to identify dozens of interventions and points of leverage for focused change efforts. And so in conclusion, we just make a few points that I think the future of healthcare that Foresight predicted is upon us now. We have innovation labs, quality improvement shops at a very high level, much better informatics than 5 or 10 years ago. We have spectacular facilities. It looks like we are aligned well to the unfolding future. But yet from a systems viewpoint, we're still running conventional clinical service models within these fantastic facilities. Health IT is not yet integrated for point of care, especially for clinical users. The models of practice and procedures have not changed visibly in many places, especially our non-urban centers. We have still serious concerns with health access equity, especially for regions like ours with very large distances to cover. There's an emerging demand for ecologically sustainable business models and public care services, and that's another system design process. So integrated system innovations are within reach when we collaborate with the system stakeholders and integrate human factors, systems, and advanced design approaches that take into account healthcare systems complexity. And that's a health journey we can all share from this day onward. So thank you and have a wonderful symposium.